For this week's case of the week, I thought it was interesting because I spent a lot of time talking about how, well, the vast majority of impressions we get are in double arch trays like this one. And this happens to be one of my favorite ones, the Clinician's Choice Quad Tray Extreme, just because of how stiff this thing is. I mean, you just really can't bend it at all because it's all metal, not plastic. So you can use really any impression material you want inside of it. If you have a more flimsy plastic tray, you need a pretty stiff material inside of it, almost a putty really, to make it so that it won't distort while you squeeze it, which is why I like this one. And I've often said that, quoted research saying that a well-done double arch tray like this is actually a better bite registration than even two separate full arch impressions that have been poured up with a bite registration sent along with it. But this is kind of an interesting case because it's something that happens fairly often in the laboratory where you look at this and it actually looks pretty decent. The doctor sent another impression with it, but wasn't quite sure what happened there at the margin. Actually, there was a little retraction cord in there that the doctor pulled out and was really close to the margin, so the doctor sent another impression. And when the laboratory went to make it, they noticed when they turned it over that even though the patient did not have a second molar on the arch that was being prepped, as we look on the other side, we do in fact have a second molar on the upper, and that in fact was in contact with the tray, with that distal bar on the Quad Tray Extreme. So if I were to hold this up to the light, and essentially we do have a light pointing down on that, you'll see that you really don't see any light on the unprepared teeth adjacent to the preparation. So this is certainly something we want to see when we hold it up to a light, is that we do in fact have some sort of contact on those unprepared sets of teeth apart from it. Here, I'll pretend it's the middle of the night and I'll take out my iPhone and turn on the flashlight. And typically when you've got unprepared teeth in contact, as you should, you'll see light right through there. If I set it right on top of my iPhone, you can barely just see a little, but it's pretty clear that those teeth aren't in contact with one another, and the reason why they aren't is the patient's hitting on that distal bar. The tray just needed to be positioned a little farther to the distal, and it was fine on the prepped arch because there wasn't a molar there, and it probably looked like there was plenty of room, but obviously on the opposing there wasn't. So what the laboratory did in an effort, because I'm one of the reasons, I'm constantly telling the technicians, slow down, don't be so quick just to call the doctor and ask for a new impression. Let's see if there's a way we can work with it. And it's not that I even feel bad for the doctor, it's that I feel bad for the patient. Coming back in, getting re-anesthetized, having a cord packed, having another impression taken. And so we're always kind of looking for a way to make it work. Unless the dentist has on their permanent notes, call me anytime there's an issue. So they mounted the case as it was here, saw it was off obviously, and so they hand articulated the models and put them together and felt pretty good about the hand articulation that they had between this upper and lower model. And then they milled the Bruxer crown that the doctor requested. This, by the way, is right out of the mill. If you ever wondered what a Bruxer crown looked like as soon as it's being done milled. It's been milled here and then sandblasted a little bit just to clean it up. And no staining or glazing at this point. If Rella Christensen had her way, and she's getting her way more often because we're trying to find ways to polish this and not have to stain and glaze it, because the glaze that we put on the surface of this crown is actually rougher, actually wears the opposing tooth structure more than the zirconia itself. The zirconia oxide is actually very smooth. So this is just literally right out of the mill and nothing's been done to it yet, which is why it looks like it's in an unfinished state. 5 years ago, this would have been white, the same color as my shirt. This would have been a very white color that you would have seen here, and it would have needed to be stained and glazed a lot. But today we're able to do it shaded, and so this is coming out pretty close to the A2 that the doctor has requested in this case. And so when this comes out and gets tried onto the model, the first thing the technicians want to know is about the bite, and it's high. So it's holding everything apart. So the bite is high on this, and they realize that, okay, well, our hand articulation didn't work. We didn't get these two arches close enough together because even though we tried to hand articulate it, this bite is high. And as they look through the doctor's case, they notice that the doctor sent a second impression, and it wasn't as good as the first in terms of marginal quality, but it was, when you look at it, a nice, full arch impression. But when you compare the two preparations themselves, even though we have a little cord there, It's a little bit cleaner on the double arch impression than it is on the full arch impression, but our success rate with hand articulating models goes way up if we hand articulate full arch models than when we try to hand articulate a double arch tray. And so we just called the dentist and said, hey, if you have the patient come by, no need to re-anesthetize them, just take an opposing impression, and they did. So this is an alginate replacement material. I'm in love with these materials, especially being here in the lab, is we can pour them multiple times. They're stable for 2 weeks. And for a dentist who's on the East Coast, sending it to a lab in California, taking an alginate impression, wrapping it in a wet paper towel and putting it in a baggie, it doesn't matter, especially during the summer. By the time it gets to us, it's shrunken. It looks like a Dead Sea Scroll by the time we take it out and try to pour it up. It looks like parchment paper, even though it was a wet paper towel. If you're going to send an alginate impression, pour it up in your office and send us the stone model and pour it well. Or just do this, take an alginate replacement. They're just as easy to take. It's basically a cheap polyvinyl impression, a cheaper version of this. It stays dimensionally stable for, again, 2 weeks. We can do multiple pours on it. And so what we were able to do was just have the patient come back, and the dentist took this impression instead of taking a new one of these. This is 2 minutes of the patient's time. This is another lower block, temporary comes off, cord being packed, being very uncomfortable. And then we were able to pour up this model. Of course, we already had the crown, and then pour up the opposing. And now when we go to hand articulate this, all of a sudden we got lots of contacts of teeth on both sides in the posterior, and we have it in the anterior as well. And we can take that same Bruxer crown and put it into place. And now everything is fitting the way that it should fit as this is in place, and it's because of the fact that we had this full upper and the full lower. And I asked him, I said, just for fun, let me see what this would look like if we poured this impression and then just mounted it all on its own without doing the hand articulation correction. Of course, that's what it looks like when the patient bites on that distal bar. You can see it's absolutely wide open there. The pin was up a little bit, but it's still wide open, as you can see when we're down, clearly a full millimeter and a half between those teeth, because the patient did have that second molar that was hitting there and keeping them from coming all the way together. So for the dentist, it would have been nice, it's always a good check for the dentist or the dental assistant to take these double arch impressions and hold it up to the light and see if you can see light coming in. And we should have contact on all these teeth adjacent to the prep where there is in fact an opposing tooth across from it. We should have light shining through there, and it should be very easy to see. The second thing is that if you do happen to see an impression like this and you note that the bite's off a little bit, know that if we try to hand articulate this, the chances of it working are about 35–40%. And like you saw in this case, even though we hand articulated it based on this 1, 2, 3, 4 other sets of opposing teeth there, we still didn't get the correct bite. And had that crown been sent to the doctor and tried in the patient's mouth, it would have in fact been very high, and you probably wouldn't have been able to adjust the occlusion enough and still had the crown look decent. So it probably would have been a redo. In this case, we've seen doctors notice this issue and send a little bite registration in with it, just on the occlusal surface of the third of the prep and the occlusal third of the opposing tooth, and that's fine. But really probably the best way is just to take another one of these double arch tray impressions, unless it's been so long that the gingivas completely come back against the tooth again, but at the same time. So even though we know most dentists for a single unit aren't going to take a full arch like this, and I wouldn't even try to switch a doctor who's doing this technique over to this technique, but do know that if you are doing this technique and you're comfortable with doing it and using this much impression material, that if in fact the bite registration's a little bit off, this gives us a great ability to hand articulate the models together and really come up with something that's going to fit well together. Whereas if the bite's off on a double arch tray like this, we either need a separate bite registration or preferably a whole new impression in a double arch tray like this. And so while, when properly done, this double arch tray does kind of represent the state of the art in terms of having a nice occlusion to be able to work with once we mount these models, when things go wrong on one of these double arch trays, they go really wrong. And when things go wrong here and we have a bad bite registration, we can still save it. So again, like most things in dentistry, there are some pros and cons to both ways of doing it, but with the vast majority of impressions that we receive, being for 1 or 2 units of crown and bridge being done in these types of double arch trays. Make sure you look that the patient didn't impinge. Try in the tray without any impression material in it before you actually take the impression. Have the patient close 3 or 4 times and make sure they can get all the way done. And that little rehearsal for you and the patient, you're going to stand a much better chance of getting this tray back in the right position. And then once it comes out of the patient's mouth, take a look at the margins and just hold it up to the operatory light or the light in the room itself. And look and make sure that you can see some light showing through the contacts of the teeth, the unprepared teeth adjacent to the preparation. If you can see all those things, there's a pretty darn good chance that your double arch tray impression is going to work just fine.